Hello, I'll be giving a presentation on the effect of Graston technique on improving scores in the Oswestry low back pain scale in collegiate baseball players. So my problem statement is that baseball players experience low back pain due to the rotational forces the lumbar spine undergoes during an athlete performing batting or pitching. And most therapeutic treatment research is focused on the upper extremity limbs, which leaves literature gaps for low back rehabilitation in this specific population. A lot of the athletes do experience either elbow or shoulder injuries just due to the nature of the sport and that it is an overhead sport, but it is leaving out an important component in those motions that these athletes are performing. So, my rationale for this is that baseball is one of the highest ranked in players experiencing low back pain. It actually is one of the sports with the highest incident rates for low back pain. And then core musculature is highly important in the mechanical motion of a pitch and or the swing. And then little research has been conducted on the Graston technique and its effects on low back pain, especially in the sport of baseball. Many clinicians do agree that no one treatment can cure low back pain, but it is important to know what works best to relieve this pain because of the such high rate of low back pain that is seen overall in athletics, and we'll look more in depth of what that looks like in baseball. So my research question is Graston effective in improving scores on the Oswestry low back pain scales in this specific population? So my purpose statement is that through this study, based on the knowledge that we already have for treating low back pain, the purpose is to determine if Graston is effective in treating this as well. So my null hypothesis is that there will be no significant difference in group one's scores on the low back pain scale and the numeric pain ratings scores, and they will be the group receiving Graston technique, and they will see no change between that group and group two that will not be receiving the Graston technique. But my research hypothesis is that group one that will be receiving Graston technique will see a significant greater decrease in their scores on their questionnaires and their pain rating scales compared to group two. They may see a little bit of change, but I would think that the Graston technique will exhibit a more significant change. So, operational definitions. Low back pain classified as pain, muscle tension, or stiffness localized below the costal margin and above the inferior gluteal folds. Graston technique is a type of soft tissue manual therapy treatment, and minimal clinically important difference reflects changes in injury status as a result of a clinical intervention that is meaningful for the athlete. So, my assumption is that the subjects will be honest about their history of low back pain in their inclusion exclusion criteria, that they will be honest in answering those surveys, and then all subjects will be honest in answering the Oswestry low back pain scale and numeric pain rating scores, that they'll just give their honest feedback on how they're actually feeling with their injuries. So, some delimitations are a history of back surgery, history of neurological pathology, vertebral fracture, or disc pathology, and that if they've experienced back pain for less than 3 months, or they have a chronic disease that causes long term immobilization. So, some limitations are the continuation of regular baseball activities, as this could affect recovery and could possibly cause re injury. So, in my literature review, I looked at low back pain, and athletes with longer careers have a higher prevalence to have low back pain, and that's at about 72%. And predisposing factors include lack of range of motion, improper mechanics, and high powered forces placed on the spinal column. Typical treatment includes using NSAIDs, physiotherapy, dry needling with intramuscular electrical stim, doing exercise for people that typically aren't active, and doing rehabilitation, but not much clinical significance has been found in these studies. For collegiate baseball players are about 3.2 times more likely to have low back pain, and about 15% of players overall experience low back pain. And pitchers and batters have the highest prevalence of having this pathology just due to the rotational force of the actions that they're performing. And force on the lumbar spine is generated from mechanical flow energy from the lower extremity to the upper extremity. And due to the force and speed of movements, any type of alterations in these mechanics can cause for injury, and more specifically for the low back pain. In Graston, so Graston is a more specific kind of the overarching instrument assisted soft tissue mobilization. So I did have to perform a generalized history search of instrument assisted soft tissue mobilization, and then more specifically look into Graston technique. So Graston is based off of James Sirax's cross friction massage rationale. The tools that are used for it either have a convex or a concave shape to provide treatment to various muscles. The concave allows for pressure to be dispersed over larger areas, and the convex gives a more concentrated pressure when providing that treatment. It's best administered after stretching or exercises, and some positive results from it are pain resolution, increased range of motion, return to normal function faster than athletes who are not receiving it, and it can also improve patient status and muscle extensibility. For the Oswestry low back pain, it's actually one of the most recommended questionnaires for low back pain. It has high reliability, test-retest reliability, convergent validity, and responsiveness to change. It assesses pain intensity, ease of personal care, lifting, working, sitting, standing, sleeping, sex life, social life, and traveling. So it really is an all-encompassing questionnaire. So the max points that a person can score on this questionnaire is 50, and then that is converted to a percentage. And based off of the percentage that the athlete has, they'll be placed into a category of disability. And the categories range from minimal disability to being bedbound. So this is a study that I saw did have some similarities with the study that I was conducting. Just some gaps that are in this study is that the population was not very representative of just kind of a general population, and that a majority of the gender was male. There was a lot more males than there were females. And then the age gap was quite large. And then the occupation was either a student or a staff member of the same school. So again, just not a good picture of a general population. The tests that were used, so the measurement tools of passive toe touch test, straight leg raise, and sitting trunk flexion meter was sit and reach test. Those tests were neither the highest levels of reliability or validity, so just not very good tests overall to use. And then Graston was only administered for 60 seconds during this treatment, so kind of calls into question, how effective was the Graston actually in this study. For the second study, we're also again looking at tissue extensibility. There were only 3 subjects in this. 6 were recruited, and then 3 only made it through the inclusion-exclusion criteria. So really not a good number of participants in this. There was 1 swim athlete and then 2 cross-country runners. Their DPAS score was 31, 41, and 7. So just kind of an outlier with that 7. So really not even starting out very well with their scoring there, not on a good even playing field. And then the pain of the athletes, they were either experiencing it, one of them was experiencing 2 weeks, and then another one was experiencing it for 8 months. So that was just, again, a large variability in just the athletes. And then not all the same special tests were used in their initial evaluations. And they also use cryotherapy at the end of their treatment sessions. And so that could also influence results and just influence scores and how they're recovering. So it's like, okay, well, how much of this was due to cryotherapy and how much of this was due to the Graston technique? So for my methodology, I needed at least 62 subjects for this to be a good study. They would range from 18 to 24 years old, so that collegiate age. They would be male, of course, baseball batters and pitchers. I went to 3 different teams, and then, of course, these athletes are coming from all over the United States, so that gave me a good demographic to be looking at. And so I was able to recruit 70 subjects. 35 received Graston and 31 were placed in a control group. Not all made it through the inclusion-exclusion criteria. For my procedures, so the subjects, they reported their treatment facility. Their athletic trainers were also recruited to be a part of this, so the subjects would be comfortable with who they were receiving their treatment from. So they did an informed consent once they were there, and then their height and weight was taken, and then they were able to begin with the study. All the individuals were given an envelope, so they would be sorted into groups and would keep the study blind, so they wouldn't know what they would be getting. So Group A received treatment and Graston, so they were the ones actually receiving the Graston technique, and then Group B received treatment and then a placebo treatment, so they had Graston just lightly rubbed over them to make it seem as though they were receiving the treatment when they actually were not. So the treatment consisted of heat pat, stretching, and core stability exercises. For the stretching, we did cat camels, child's pose, and double knee to chest. For exercises, we did bird dogs, glute bridges, and prone Superman holds. So before and after every treatment, the low back pain scale and the numeric pain rating scale, those were both used so that we could track recovery that way. So a treatment occurred every other day for 14 days, and then 2 subjects did have to be released due to re-injury while continuing in the sport. So data analysis, I wanted to compare the pain scale scores and survey scores averages and standard deviations. I was looking at pre to mid treatment, mid to post treatment, and then the overall pre to post treatment. I just wanted to compare, okay, how did these groups do overall from beginning to end? How did they do at the beginning half? How did they do at the latter half? And I used the 3 separate t-tests to see if there was a significant difference with my p-value set at 0.05. And then I put my averages and standard deviations for my pain scale and survey scores, all of those results into SPSS. So in conclusion, this study was conducted in order to bolster research on treatment for low back pain in baseball players and batters by using Graston technique. Like I said before, a lot of their injuries are upper extremity, but that doesn't mean we ought to neglect injuries that do happen in the lumbar spine, as they're crucial as they serve that link between the upper and lower extremity. Studies that use Graston and their treatment on low back pain in this population is very limited. There's not a lot specifically for this population, for this pathology, and so this lack of research has caused no continuity with instrument selection, treatment times, and outcome measures. And so while this is an important type of, or a popular form of myofascial therapy, the small amount of evidence does provide little support. And so the overall purpose of this is to give athletic trainers more support and more evidence for their evidence-based research practice. That is all that I have. Thank you so much.